Well, we're going to talk about our experience here with SCID, and we're going to talk about how we're going to evaluate patients and try to give you some understanding of the personal toll that this disease has taken and the potential benefits for early intervention. So our objectives are to understand the local availability of SCID services, to know the referral process, to review some recent local cases, and then contrast the patient experiences without SCID screening and with SCID screening. So what we offer is initial evaluation of patients. We can order and perform diagnostic testing. We can arrange for hospital admission, and after evaluating the patient, safe home care. We can start prophylaxis with against pneumocystis, Candida, start monthly IVIG. We will share the information we obtain with our UCLA partners, and we've organized today their ability to look at our patients through EPIC, which both of our centers use. We'll be able to interpret the laboratory tests that we get, plan for and arrange with Randy Wada and our colleagues at UCLA, bone marrow transplant, gene therapy, and provide counsel and support to the patients in their own location. So you have a positive newborn screen, and you're the doctor. So who are you going to call? Well, it's not Ghostbusters, but it's us. And we are located in Suite 1010 at Kapiolani Medical Center. Most of you have reached us by telephone many times, so you can reach us through our hospital operator, through our clinic office, or sometimes through our cell phones. And to talk about the tale of SCID for the patients that we've seen, we have seen within the last couple of years 2 SCID patients that came to us late, and through our collaboration we've already been dealing with a potential SCID or a functional SCID in a 9-month-old boy with intestinal failure, and we are currently on the 31st day of our evaluation of our screening program, have identified a potential SCID patient, certainly a patient with lymphocytopenia. So the first case is a 9-month-old Neighbor Island girl who had trouble from early in life. She had had diarrhea, otitis, failure to thrive. She had persistent salmonella bacteremia that needed prolonged IV antibiotic therapy. She had an episode of prolonged severe varicella that was ultimately treated with acyclovir for a very long period of time, over a month. And at the time I first saw her, she had severe pneumonia due to pneumocystis. When I first saw her, she was very listless, tiny, very thin infant. She was in respiratory distress. She had white patches on her oral mucosa. She had absent tonsil tissue, and she had a diffuse scaly rash over her body and many old scars from varicella. Her lymphocyte profile showed decreased total lymphocytes, near absent T cell and NK cells, and normal levels of B cells. Her IgM, G, and A were all very low. She had no antibody responses, although she had received primary immunizations. She was ultimately diagnosed to have autosomal recessive JAK3 deficiency, which you've already heard described in much better detail, where the B cells maturation was blocked at the pro-B cell stage. And this was not the most common form of SCID, but it is a common form of SCID. The most common form of SCID is the X-linked due to defect in the common gamma chain. So this is another iteration of the gene defects. I meant to use that as a pointer. Well, this isn't a pointer. Where is it? Top. Okay, so that's the defect that she had. And as these numbers are somewhat fluid, but it's a considerable portion of true SCID, and this is the most common form. And this is just another way of showing you the various defects and what they interrupt. So that patient was referred for a bone marrow transplant. That patient went to Duke. This is a second case. This is our most recent case that has been referred for transplant. This was a 10-week-old boy. He had been born after a normal pregnancy, the first child to his parents. He had a fever and was diagnosed with otitis media. He was given a prescription for amoxicillin for 10 days, and he was repeatedly examined because his fever didn't go away, but the exams were apparently within normal limits. He was continuously febrile for 17 days, and then he had a seizure. That did lead to his first workup for sepsis, and he was found to have E. coli meningitis. Because he had very severe meningitis, because repeat taps did not continue to show the organism, but continued to show considerable white cells, and because he was he had intractable seizures. He was in the intensive care unit for a very long period of time. We treated his meningitis much longer than we usually do, treated it for 31 days and stopped. 3 days later, he was abruptly in septic shock. He was found to have recurrent E. coli meningitis, and at the same time he had E. coli, Klebsiella, and Enterococcus in the blood on that day. We did T-cell studies, and we found that he had abundant T-cells, had abundant lymphocytes, excuse me, and he had abundant T-cells. He was confusing because he had very few B cells and plus minus NK cells. He had absent immunoglobulins at the time he was tested, which was then about 14 weeks of age. Gene testing, though, showed us that his T cells were of maternal origin, and they were all CD8s. So he was found to have the X-linked common gamma chain receptor gene abnormality. He was transferred to Cincinnati Children's Hospital. He failed 2 attempts at gene therapy. The first was because of the maternal engraftment of the CD8 cells, so they were ablated. It was a second attempt at gene therapy was done, and I'm not certain. I know that failed. I'm not certain why that failed. So now, nearly 2 years after he left Hawaii, he is still at Cincinnati, and he is about to undergo bone marrow transplant. So his family is currently preparing for that. Because of the devastating meningitis, he has some developmental delay, but he is making progress. He, along the way, developed pneumonia and various other problems. He's off of oxygen. He's no longer needing G-tube feeding. He's seizure-free. He gets IVIG, Bactrim, and fluconazole, and he's had no recent infections, so they have been able to maintain him without infections. He completed long-term treatment for cytomegalovirus. So this is a patient who cost a great deal of money and certainly had a great deal of disease and pain and disability as a result of this. He showed up at 10 weeks, and there were no prior indications that he was abnormal. So he fits it perfectly. This is a patient of that when we were just establishing this relationship, before we started the screening, we found in our hospital a 9-month-old boy who had severe diarrhea. He had very low circulating lymphocytes from birth. In fact, every CBC that he ever had showed total lymphocytes were very low. In the same week, he developed staphylococcal and candida bacteremia. He was found to have low immunoglobulins. His T cells, B cells, natural killer cells were very low. And he was also markedly hypoalbuminemic. He had gastrointestinal protein loss, which we knew about, but until this was done, people were not aware that he was also losing all of his lymphocytes. He was found by, after consultation with our colleagues at UCLA, and discussing the severe protein loss which he was having, we focused on, at their suggestion and ours, we focused on his gastrointestinal disease. He had 3 upper GIs which had not shown any sign of malrotation or volvulus. He had already had 3 EGDs. And when we told Dr. King that the problem was his and he'd better fix it, he was very annoyed. He said he'd done everything he could think of, and this was still the problem. So we were saying, well, he has no lymphocytes. Maybe he has something wrong with his bone marrow. So on the same day, we set him up to have a bone marrow and to have another upper GI and have another scope, and also threw in a CT of the abdomen. And the CT of the abdomen showed intermittent twisting, showed that he had volvulus at that time. So what happened with him was he had intermittent twisting or intermittent volvulus, resulting in damage to his intestinal mucosa and the outpouring of proteins, antibody, and lymphocytes. Following this, we had continued him on IVIG for about 3 or 4 months. He is now coming off of that, and he has had month by month an improvement in his lymphocytes, so that he is also no longer has diarrhea. His bowel function is now good, and he's gained weight, and he is basically a normal child. But he would have fit the characteristics of SCID with very low levels of T cells, B cells, natural killer cells, and low immunoglobulins. And then finally, this is a term baby who was born to a mother with diabetes, delivered by emergency C-section for severe maternal hypertension. She had multiple anomalies at the time of birth. She had hypertrophic cardiomyopathy due to non-compaction. She had multiple vertebral abnormalities. She had a right-sided cleft foot. She had a tantalizing finding of a persistent left superior vena cava, and was in our NICU on day 11 of life when NICU was called to say that her newborn screen showed no T-Rex. So while the child was still in the hospital, we were quickly able to get our T cell profile and lymphocyte profile, and she showed that she had very low T cells. She did have B cells and natural killer cells. Her gene testing, however, showed no abnormalities in the 18 known SCID genes. Various other testing ruled out gene abnormalities associated with classical DiGeorge syndrome. This patient has never had an infection. She was hospitalized and is now on home isolation. She gets IVIG monthly. She gets Bactrim and fluconazole prophylaxis. She is clinically thriving. All of her problems are actually improving. She's gained weight extremely well despite her feeding problems. She does get oral feeds plus G-tube feeds. And although we are searching for a bone marrow donor for her, we have also noticed slight improvement every month in her CD4 cells. So we're not certain exactly where she is going to fall. If she doesn't show improvement to normal levels, we will be needing to look for a new novel mutation causing her problem, and that will need to be done by whole exome sequencing. So those are the stories of the patients that we have seen in the last few years, mostly in the last 2. Now this is what one of the mothers of the child who went to Cincinnati has written. She wants to be the poster mom for SCID in Hawaii. She doesn't want any other family to go through what she had to go through. In the first place, he had a life-threatening illness that took about 2 months before we could get him in any shape to move to another center. He has a developmental delay. They have been, they knew nobody in Ohio, and they've been living there now for 2 years. The father still works at his job here, and she communicates a lot with iPad, and he have lived in either the Ronald McDonald House or a small apartment the whole time they've been there. And he's still facing a somewhat uncertain future. So I think this shows better than anything the reasons why we should be moving forward to early identification and reconstitution.